I would love for every person who is diagnosed with bronchiectasis, from someone from Halifax to Victoria, who has access to education, prevent comorbidities. So there's education that can be given to prevent these comorbidities. That's the big dream.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
Welcome, everyone, to this podcast on COPD, bronchiectasis, and airway clearance. We have Isabelle LeClerc here, who is a registered nurse, and we are going to discuss about COPD, bronchiectasis, what it is about, the symptoms. Is there any way that we can make people's life better with the symptoms of productive cough that many of these patients may have? A lot about airway clearance as well. And there are techniques that can be teach to the patient. There are also devices such as Aerobika. In addition to the interview, Isabelle is going to take some time to show you what these techniques are about. Also, the use of Aerobika. Isabelle LeClerc is a registered nurse with over 35 years of nursing experience working in Ottawa. For the last 25 years, she has worked in an interdisciplinary academic primary care setting. She's a regular presenter at the Canadian Bronchiectasis Education Support Group. She has presented poster, given workshop, and webinar in Canada as well as worldwide. Her passion for helping patient management and manage their health has taken her around the world, from providing continuous medical education to clinician in Canada to attending World Bronchiectasis Conference in different European countries and United States. Please keep watching all the way until the end, as this podcast will give you extra material to cover specific technique and device such as Aerobika for helping patients with airway clearance. If you're listening with only audio today, you can always visit our website, chroniclungdisease.com, to watch a video of the technique. Welcome, Isabelle, for the podcast on bronchiectasis. We're very pleased to have you with us, and please tell us what made you interested as a nurse to a chronic airway disease, and then particularly to bronchiectasis.
Well, I've been a registered nurse for 38 years, and I was working in a primary care academic setting. I've been working for 25 years. And then I knew about COPD and I knew about asthma. But back in 2013, I was diagnosed. I ended up having severe pneumonia. And eventually, 2 years later, I was diagnosed with the third most common chronic lung disease, which is bronchiectasis.
Oh, my gosh.
And then that's when I actually decided I was going to learn as much as I could about bronchiectasis. And I attended yearly international conferences. We started in 2016 with the first World Bronchiectasis Conference in Germany, and then Italy the year after, and so on. And since I was already leading a chronic disease program for different diseases, I developed a bronchiectasis self-management program that in the beginning, it was really to concentrate on our population in our clinic, but eventually it grew to include all of the bronchiectasis patients in the greater Ottawa area. So I work with all of the respirologists in this area.
It's kind of interesting, happy in the sense that you got bronchiectasis, because you wouldn't probably had the same interests. Okay, I hope you're doing well and you're managing well, and not only for your patient, but what are the patient main complain that, because we hear a lot about asthma, we hear more and more about chronic obstructive pulmonary disease, COPD, and but bronchiectasis, it sounds like we don't hear so much about it. What are the patient main complaint when you see them?
Well, receiving education is the main issue, and knowing where to receive education is what I hear about a lot. So patients with chronic lung disease, well, they need to understand how the chronic disease can actually affect them on a daily basis, but they want to learn how to better self-manage. So I'll give you an example. Patients come in complaining of shortness of breath, but that can actually affect their exercise regimen, just going up some stairs. And then if they complain of a chronic productive cough, that makes them very uncomfortable in a social setting, even worse since COVID. And then you've got complaints that they're complaining about fatigue, and that can prevent them from doing just what we consider normal daily activities. So patients want to learn how they can improve their function. So knowing where to get education, where to receive education, that's the main challenge for these patients.
And then no matter how often you see the patient, you're right that the patient has to live on a day-to-day basis and within the day, how to manage and what you refer to self-management, that the patient know more about dealing with the condition, adapting, and having healthy habit. Okay, tell us a little bit more about what are this self-management that we're referring to in these respiratory patients. What are the different strategy that the patient has to adopt on a day-to-day basis?
So when I teach self-management, it's really giving the patient, first of all, education on their chronic disease. Remember, I lead different chronic disease programs. So, and then I motivate them to change their lifestyle, to improve their quality of life. And we have discussions for any chronic disease. We have discussions on nutrition, smoking, alcohol, caffeine, exercise, sleep. We talk about stress, how to better manage stress. And then as well for bronchiectasis, well, we talk about airway clearance techniques. And then self-management continues because I follow up with them on a daily basis and I review the goals they had chosen at the first visit. I review the lifestyle changes that they chose to make. And then I support them through those changes. In the bronchiectasis program, I really keep close communication with their family physician because a lot of them come from outside of our clinic. But I really keep close communication with their respirologist as well with any health changes of those patients.
Then since it's a chronic disease, people have to understand that we cannot cure. It's not like a pneumonia, where obviously if you give antibiotic and then after a certain time, you are going to be cured. But we're talking of a chronic disease. We're talking of damage of the airway that result from a different condition that you mentioned, an infection, like the pneumonia you had before. And that condition is chronic. Then the patient has to learn to live with some of the inconvenience, but be healthy in disease in a sense, okay? And one of the main problem, it's airway clearance in bronchiectasis because people produce, many of them, more secretion. Then a lot of the work that you're doing, it's about prevention. Tell us a little bit more about this notion of airway clearance, and then we can talk after more globally about prevention for these patients, that we can prevent infection in bronchiectasis.
So we'll talk about strategies and then airway clearance techniques. So when a patient has symptoms like a daily productive cough, specifically in bronchiectasis, shortness of breath, or even fatigue, they need to learn different techniques to better function. Number one, so if they have shortness of breath, I usually teach them specific positions to help alleviate shortness of breath. Okay. And then if they have this chronic productive cough, specifically in bronchiectasis, that's typical, then I will teach airway clearance techniques. And it's really techniques to get the mucus out of their lungs. Okay. So including all the other strategies, managing stress and improving exercise. So daily airway clearance techniques, it really does decrease symptoms like a productive cough and shortness of breath. And it really improves the gas exchange in the lungs so that the patient can actually get better ventilation in the lungs. We know that it does that. It also helps reduce exacerbation because it gets the mucus out of their lungs, mucus that has bacteria. Even with that, what the best motivator for our patients who've already been diagnosed with pneumonia, they may have had severe pneumonias and a few of them in the past. When we tell them that this may decrease their next exacerbations, it really is a motivator for them to get involved and do active cycle of breathing. And there's different ways to do airway clearance techniques.
Is there, that's very interesting, because we wouldn't think about necessarily that you can prevent, and what you want to prevent, obviously you want the patient to have some of these symptoms alleviated, such as shortness of breath, control of the cough also, and you also want the people, to prevent those flare-up that are often infection-based, that would need to be taken antibiotic and being seen in a clinic and sometime in the emergency room. But the clearance of the airway, is it something that some device can help? Is there a device that can be used to facilitate the airway clearance?
Absolutely, because there's many different airway clearance techniques. Some of them, and we need to teach a few of them to our patients, because they need to feel in control which one they're going to use and which ones works best for them. So there's specific breathing exercises like active cycle of breathing and autogenic drainage. There's different position, we call positional drainage or gravity assisted drainage. And then there's specific devices. And we call those OPEP devices, so oscillating positive expiratory pressure device. And that really is it's a drug-free device, actually. The patient breathes in and out through this device. When they breathe out, the oscillation or vibration actually loosens up the mucus from their lungs. And the positive pressure keeps the airways open so that the mucus, and oftentimes filled with bacteria, is actually mobilized up the airways. And then they can just cough it out.
Okay.
So we can even talk about guidelines regarding OPEP devices, because they've been mentioned in different guidelines as well.
Yeah, the people have to understand, and when you have bronchiectasis, there's damage of the mucosa in some area of the bronchial tree, and that damage, because the mucosa has ciliary, and those act like escalator, and they kind of move up, the mucus, and then when you're losing those, then those devices will not replace the ciliary, but it will replace, in a sense, by the oscillation, the capacity to mobilize those secretion. Then I think the device, like you mentioned, and they're not big device, if I'm right, and they're relatively small device, and they're relatively affordable also for the patient.
Absolutely. It's a small device, drug-free. It's handheld, so it can hold in their hand. And they're very easy to use. They breathe in and out. And what patients need to know is there's great YouTube videos to use these devices. It'll teach the patients how to use it, but it also teaches the patients how to clean and sterilize their device, which is very, very important.
Yeah.
Because bacteria from the lungs are actually coughed out or breathed out when they use their device, and we don't want them to breathe back the bacteria when they're going to use it again in the evening, because they're usually airway clearance technique is recommended to be done twice a day.
Absolutely. And for people who may not be familiar or have heard the term OPEP, people may have heard the term a cappella, flutter, Aerobika, just to mention some of those devices that some of the patient may have. We've been talking of non-pharmacology. You just mentioned non-drug. Those are non-drug treatment. Then in the treatment of bronchiectasis, as we mentioned earlier on, there is no treatment to cure. But it doesn't mean that there is no drug treatment. And if we include the vaccination, for example, and maybe we can talk later on about the drug treatment beside treating a flare-up, an exacerbation that would require an antibiotic. Vaccination, is it something that a patient should really ask their physician or their nurses, and which one should we be considering?
Absolutely. So again, we fall into the guidelines, and I'm in Ontario, so you're in Quebec, so there may be different recommendations. But flu vaccine, absolutely every year, as well as now there is the RSV vaccine, which there's specific recommendation with age. There's another one called the Prevnar that's against pneumonia. Every person with a chronic lung disease should have their Prevnar. There's Prevnar 13, Prevnar 20, but also there's the COVID vaccine. They should stay up to date with all of their COVID vaccinations. Those are really part of self-management, not only changing lifestyle, but as well as doing airway clearance techniques twice a day, but vaccination are part of self-management.
Yeah, and you're right that depending of the recommendation are at the national level, and they're but like drug medication, their listing is at the provincial level, and pretty much across the country now, flu vaccine and COVID vaccine is available for free. Depending of the province you are, the age you have, the underlying chronic condition, comorbidity you have there, some of the other vaccine might be a cover, but not necessarily the one that are the most up to date, like you mentioned, the Prevnar 20, for example, to prevent streptococcus pneumoniae, is available for free in a very rare condition, and not necessarily in bronchiectasis. And the RSV, depending of the province, some province have started to cover certain group of patients, especially the age population. And this is something you really have to ask to your physician. Then if it's not covered, you still have access to it, but you have to pay for those vaccines. Yes,
exactly.
Isabelle?
And I forgot to mention a very important was Pneumovax 23. That's another one.
That one is free. Yeah.
If you're covered after a certain age. So that's I know about Ontario. After the age of 65, you can have it. If you have a chronic lung disease, you can have it before the age of 65. Absolutely.
Then there are some preventative treatment also that if you speak to your physician, especially if you have recurrence and infection flare-up, and these are also according to guideline, where certain preventive antibiotic, although they're not necessarily given specifically for their antibiotic effect, but their anti-inflammatory effect, and they can prevent some of these infection to be so recurrent over time. When we have taken care of all, then there is a lot to be discussed with the physician. They are with the nurse also. In certain area, there's going to be a whole team working with the patient. We've been talking of pulmonary rehabilitation very often with COPD, chronic obstructive pulmonary disease. But what would you see in now and in the future? Because some of these patients have deconditioning. They have to learn about living with their bronchiectasis with some medication they have to take, or non-drug treatment like you just mentioned. But what about pulmonary rehab? Is it something that we should really expand beyond a COPD?
Absolutely. And their guidelines recommend that as well. I mean, there's a respiratory breathlessness score. And then some of the guidelines say if the patient has a score of 2 or above, he should be recommended respiratory pulmonary rehab. I'm not too sure that's actually being done everywhere, because if the patient is going in to see their family physician, they're complaining of shortness of breath, I don't know if that scoring is done at every visit. But absolutely, because that's where patients get a chance to learn. So when patients are referred to either in Ontario, we have COPD community, free community clinics. But when the patient has a chance to be referred to one of those COPD clinics or referred to community or even in hospital pulmonary rehab, they will learn how to better self-manage. They will learn airway clearance techniques, more than one. And that's where they can learn how to, if they're deconditioned, how they can learn to improve their function. So absolutely, pulmonary rehab is an option. I mean, we have to think of Canada as a big country, and rural area may not
Hmm.
have pulmonary rehab, but it's important to know as well if it's available online, that patients need those resources to be given to them.
It's you just mentioned about those clinic that we have in certain maybe large city, but I think it's important to know that this condition bronchiectasis can be taken care by physician. Although when there are complication and it seems that the problem is recurrence, especially in terms of infection, it is important to see if you have a clinic that is specialized in bronchiectasis in your area, or you could have access to one of these clinic. And what would be the best way, Isabelle, for patient to know, or their physician also, because we could have physician, nurses that work with a patient that have bronchiectasis and would like to refer these patients. Would it be to go through the Provincial Lung Association? Is there a place where we could find out, okay, where to refer these patients?
When we think of, there's more education available for COPD compared to bronchiectasis. Bronchiectasis still, it's getting a lot better since the first World Bronchiectasis Conference in 2016. But absolutely, if patients are able to get some information, I mean, there's online resources, even through COPD. If there's the Living Well with COPD that's have a specific module about how to do airway clearance techniques. That's what they need to learn. In Canada, we do have the Canadian Bronchiectasis NTM Education and Support Group, which has been led by a coordinator in Toronto for the last 20 years. Wow. And that is now, since COVID, it's a virtual platform. Well, all Canadians with first a diagnosis of bronchiectasis, but remember, they often have an overlap of COPD. They often have an overlap of either pulmonary hypertension or asthma, heart failure even. But if they have a first diagnosis of either bronchiectasis or NTM, this is a great resource. And I'm involved in this platform with education 2 to 3 times a year to all of these Canadian patients. And we have guest speakers. Often our guest speakers are respirologists from Canada, as well as in the United States, who specifically either speak on bronchiectasis management or NTM, which is non-tuberculosis mycobacteria pulmonary disease, which is often found with bronchiectasis, unfortunately. It's a completely comorbidity. It's a completely different disease than bronchiectasis, but often there's a link between the two. So we have guest speakers, we've had kinesiologists, we've had dietitians. So if patients can get information of how to join this platform, they will absolutely learn how to better self-manage. As well, there's Respi Plus, which is Living Well with COPD, and they have the French version, which can help as well. And it's important for patients to get evidence-based websites, and not to try to find things online that are not evidence-based. So it's often important to get the right recommendation.
It's true, and maybe through Respi Plus we could also link better with your network, and that way people can access some of these either material or some of the training you are offering, some of the speakers sometimes for healthcare professional, because bronchiectasis is an area that we are obviously getting more interested now. Like you said, it could be associated with other chronic airway disease, like in severe COPD. At least 30% of the patient who could have associated bronchiectasis, and those patients obviously would make us think differently in terms of the treatment and preventive treatment, because these people tend to have more recurrence and infection. But this area is kind of changing now. There is more interest. Some patient group also, like in the United States, the COPD Foundation also combine bronchiectasis, and then in Canada, I don't think we have started going that way, but this is really an area where we're going to hear more and more, okay, about discovery, better treatment management, and self-management. If you had something to say to people that had listened to us, what would you say about self-management and adding to what you have already said, okay, on the management of these disease, where people feel maybe isolated? What can I do and don't know what to do?
That's such a great question. And it brings me I also lead a hypertension self-management program. And I remember showing a picture to a gentleman who wasn't able to read or write. And I showed him a picture about different foods that they were high in salt. And he had tears. He was an elderly gentleman. He had tears in his eyes. And he said, why didn't anyone ever show me this before? So education, patients just want to know. So self-management, it has to be offered to every chronic disease, not only chronic disease, chronic lung disease, because patients want to know how to better function. They want to know how to live better and especially improve their quality of life. But in chronic lung disease, they want to know how to prevent another exacerbation. If they can avoid going to the emergency department and especially being hospitalized, they will learn how to better self-manage. It's a great motivator. And there's one thing you said earlier about management when patients have a lot of exacerbations. Of course, we think of the bronchiectasis guideline from 2017 at the European Respiratory Society guidelines, and then the British Thoracic Society guidelines as well. I sometimes will call patients. I have a follow-up and then they tell me, well, I've had 3 exacerbations in the last 1 year, because I ask them every time, how many exacerbations have you had in the last 1 year? And they usually have a rescue antibiotic waiting for them at the pharmacy, and that's usually prescribed by the respirologist. But they can also go to a walk-in clinic or a family physician. And they haven't told the respirologist that they've had 3 exacerbations in 1 year. So that's where we need to ask our patients, because they won't think it's important. But we know because of the guidelines that management will change. We have to review what they're doing for airway clearance techniques. And like you said, there may be a prophylactic low-dose antibiotic that will be prescribed in some cases just to prevent another exacerbation. Because we know that exacerbations, they drive disease progression. And then we need to teach that to our patients, that these are information that may be simple to know about how many exacerbations you've had in the last 1 year, but we need to ask.
Yeah, and then you mentioned about the rescue medication, although, it's easy to prescribe an antibiotic and tell the patient that, when you have an exacerbation, you take that antibiotic. But that requires also what we often use the term action plan. It requires some education also, some supervision and communication as well. What is your experience of this with your patient, Isabelle?
So I give an action plan to all the patients that I see. I've developed a bronchiectasis action plan, but there's also great ones there's a website in Australia that has a great action plan already determined. And the guidelines are the same. If you've had 3 exacerbations, you need to speak about it. But then the symptoms of an exacerbation, those patients, they've had pneumonia before. And they know when all of a sudden they don't seem to be at their baseline. And then we know that the last published recommendation for prescribing antibiotics for an exacerbation in bronchiectasis, there's specific symptoms. And if those symptoms have been going on for more than 48 hours and the patient's not getting better, just getting worse, then they are to start the rescue antibiotic. It will prevent them from going to the hospital and going to emergency. And it will prevent them from having a full-blown pneumonia. So we need to catch it sooner. This is all education that is part of an action plan, part of giving all this knowledge to the patient so they're independent. But you're right. Often when they call, and they call me at the clinic, they will tell me, recently someone called and said, I've had hemoptysis for the last 3 days. I've tried to reach my respirologist, who said, call your family physician. I can't see my family physician until the next 5 days. What do I do? So they do have the action plan with them. They've looked at it, but they just want to make sure, is it okay to start the rescue antibiotic? so they have access.
Yeah.
It would be great in every city in Canada. That's my dream, that someone would have access to somebody like me over the phone just to confirm with them, yes, it's okay, start your rescue antibiotic now.
Absolutely, and then this is something we should have as part of a practice, and not only for diabetes or other chronic condition. And you mentioned about hemoptysis, and this is blood in only blood or blood in the secretion, and the patient should be advised that if they have hemoptysis for the first time, they really need to consult for that. If they are known to have some streak blood with an infection, then they can take their action plan. But if in any way this is more important, or if it's hemoptysis only with blood and no secretion, they really have to go to the emergency room and consult for that, because hemoptysis is a condition that we see occasionally with infection, with chronic bronchitis, but we're going to see more often with patients that have bronchiectasis. And if it turned to be more important, then there are also treatment that can be done for that other than antibiotic, but those treatments are only possible in an hospital setting.
Exactly.
Then you tell us, and I'd like you to conclude, Isabelle, about your vision. You said my dream would be, but your vision in the next 10 years. Let's plan realistically, and what would we like to see in Canada in the next year, 10 years, for this condition, chronic airway condition, bronchiectasis?
Wow, what a loaded question. It's a great question. First of all, in Canada, there are registries for certain diseases. That means that we can count and tell how many people have a certain disease within Canada. There's not right now a registry for bronchiectasis.
Okay.
But there are two respirologists out in Calgary in Alberta who are working on the first bronchiectasis registry. And hopefully in the next, not 10 years, but in the next 2 years,
Okay.
that will be offered to all of Canada. So we can know how many people have bronchiectasis. Is this something really on the rise here in Canada? And then before that even happens, I would love for every person who is diagnosed with bronchiectasis, and the diagnosis for bronchiectasis, it has to be confirmed by a CT scan. Often it's not seen on
regular chest X-ray.
On an X-ray.
Yeah.
But as well, when I think of family medicine residents who are coming in to do their family medicine residence, because we are in an academic clinic, giving them knowledge even in medical school about how to recognize the sign of symptoms of bronchiectasis, because the patient's going to go in primary care complaining of a chronic productive cough or repeated lung infections. So giving awareness and more education to the family medicine residents, the family medicine physicians about this is a chronic disease. And when they look at the EMR, they have to write it in the EMR as a disease because they'll see it on a CT scan. And then absolutely refer to education. Refer to education, decrease disease progression in most of our patients. That's my dream. And from someone from Halifax to Victoria who has access to education to prevent, first of all, prevent comorbidities like heart failure. There's a link with bronchiectasis. Pulmonary hypertension is a link with bronchiectasis. Non-tuberculosis, mycobacteria, pulmonary disease, there's a link. So there's education that can be given to prevent these comorbidities. That's the big dream.
It's a very well way to end this podcast, because the podcast is first to increase awareness of the patient, of the public, and also a physician and healthcare professional. This is a condition that is present in the Canadian population, and we often don't recognize, and there are certain symptoms that should make us think about it. Like you mentioned, it requires usually a CT scan because it's not seen on the regular chest X-ray. And then there are treatment, not to cure the condition, but there are treatment pharmacology and also non-pharmacology that goes through education and self-management that would make you living with your bronchiectasis and preventing the progression and the complication of this chronic airway condition. Thank you so much, Isabelle, and hope in the future that we can invite you again to launch maybe some of these programs in Canada and the change in 2 years that we have, okay, about bronchiectasis in Canada. Pleasure.
Thank you very much for having me. Thank you. When we talk about airway clearance techniques, we need to teach different airway clearance techniques to our patients because the best airway clearance technique is the one the patient is going to be doing. So there are different ones we can teach our patient. One of them is called active cycle of breathing. There's also other devices that we'll talk about in a few minutes, OPEP devices. There's sometimes something called autogenic drainage and postural drainage. We know that the 2023 GOLD guidelines for COPD and the 2017 European Respiratory Society guidelines for bronchiectasis, they recommend using an OPEP device for our patients who either have COPD or bronchiectasis. I would like to talk first about airway active cycle of breathing. So active cycle of breathing is a 3-phase cycle. The first phase is really controlled breathing. So I ask patients to take 5 regular breaths. The second phase is actually thoracic breath. So it's a deep breath in. The patient holds his breath or her breath for about 3 seconds. And that lets the air go behind the mucus so that the mucus can actually travel from the smaller airways up the bigger airways and actually up to the throat so that the patient can cough it up. And the third phase, it's a forced cough, or what we call a huff cough. It's really where the patient needs to keep the mouth open in the shape of an O. It keeps the airways open. And it's a fourth cough. It's a forced cough. For example, that's a huff cough. So it really keeps the airways open. These 3-phase cycle keeps the airways open, helps mobilize the mucus up the airways, and actually then force the cough and the mucus out of their lungs. The other airway clearance techniques that it's recommended by our guidelines, it's called an OPEP device. An OPEP device is an oscillating positive expiratory pressure device. This is a drug-free device, and it helps loosen up the mucus from the lungs. It helps mobilize the mucus up the airways, again, so it can be coughed up. OPEP, because there's an oscillation, I can show you an example of an OPEP device. This is one of them that is commonly used in Canada. It's called the Aerobika. So when the patient breathes out, this is the mouthpiece. When the patient breathes out of the OPEP device, there's a little oscillating, which is inside the device that helps vibrate the bronchial tree so the mucus could be loosened up. And then there's a positive pressure that keeps the airways open so that the mucus actually travels up the airways. And again, the patient would take about 10 to 15 breaths in and out, hold their breath on the breath in, hold their breath for about 3 seconds, and exhale slowly through their device so that the mucus can actually move up the airways and be coughed up. So the great thing is about some of these OPEP devices like this Aerobika, sometimes the patient needs to take a nebulized saline. You would put the nebulized saline in the nebulizer, and to save time, actually the patient can choose and have the option of doing both treatments together by putting the nebulizer on the OPEP devices. And you can see that it would save time. A nebulized saline takes about 12 to 13 minutes treatment. And an OPEP device, we recommend 20 minutes, maximum 30 minutes per session because it can cause fatigue. And that's usually done twice a day. So you can see with this option, the patient can actually have an option of saving time doing any airway clearance techniques during the day. Now, we know from studies that were published for COPD in 2016, 2018, and 2019, that the use of an OPEP device improves lung ventilation, it improves lung function, it improves quality of life, and it decreases exacerbation. And this does also decrease healthcare costs because there was also a study that was done in 2019 Now, in bronchiectasis, there was a recent study this year in 2023 that showed evidence of the same outcomes for patients with bronchiectasis that were using an OPEP device. So airway clearance techniques by using an OPEP device will decrease symptoms like a daily productive cough because it works to clear the mucus from the lungs. We know that exacerbations lead to more inflammation in the lungs. It drives disease progression. So in bronchiectasis, some patients need a nebulized therapy like hypertonic saline with an OPEP device. So doing the combination treatment, it actually helps them save time and it improves their quality of life. So I hope this little module about airway clearance technique could make things clearer for you to help your patients. Thank you.
Thanks for listening to the Expand podcast. This is season 3 on COPD. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.